Now, having considered the reasons why we need to treat hyperglycemia, what we really need to look at is what are the considerations. So, when you have a patient who comes to us in the hospital, we obviously need to evaluate this patient and see where are the target goals that we're going to look at, what are some of the precipitating reasons, and what would be the most optimum treatment that we would need to give our patients. One thing is very clear, that patients who come for a longer stay in the hospital, there is very limited role for oral agents. Majority of our patients will be on insulin therapy because there are various reasons why oral agents would probably not be acceptable when the patients are in for some acute problem. We know that metformin is contraindicated in liver disease, renal disease, advanced cardiovascular disease, and some of the other drugs that can be used, but we need to be very cautious about these drugs, is short-acting sulfonylurea, but monitor for hypoglycemia. Alpha-glucosidase inhibitors can be used, but be careful because sometimes alpha-glucosidase inhibitors can cause a lot of GI intolerance, and for a patient who's in the hospital has poor appetite, this can get aggravated. There has been good evidence about DPP-4 inhibitors because it sort of reduces the dose of insulin that we need to give, and in turn sort of reduces the rates of hypoglycemia in our patients. We can combine oral agents with insulin, and there have been robust trials of DPP-4 inhibitors with insulin that has been given in acute care. Now, we know that when patients come to us, they can come to us either they are pre-diagnosed with diabetes and then they get hospitalized for some reason, or for the first time they are detected to be hyperglycemic in the hospital. Now, when they are detected for the first time in the hospital, then we know that there could be two reasons. Either they were undetected prior to hospitalization, or they get something what we call as stress-induced diabetes. Now, either ways, whatever we may say, all these patients who are hyperglycemic need to be well controlled. We know that the stresses of hospitalization can cause hyperglycemia, and for a good perioperative glycemic controls, we need to keep the sugars under a good control. This is particularly true in the post-surgical period, where immediate post-surgical period, if we keep their blood sugars well, the outcomes are much better. Now, there could be that patients are obese, they are hospitalized, and they may be insulin requiring, and could be that there would be variability in the amount of insulin they would need. The insulin requirement may go up because of increase in the insulin resistance because of the primary illness, or they could actually go down too because of poor eating and they're not eating adequately. So, all these may be potential reasons why somebody would probably have variable insulin requirement, and what this brings us to the point is we need to monitor them more closely. We need to do frequent blood glucose testings, which will help us to regulate the dose of insulin that we need to give the patients. Now, these are some of the metabolic responses of hospitalization and surgery. They do tend to develop an increase in the insulin resistance. So, for some patient who was well controlled on a particular dose of oral agents or on insulin, you may find that there is a sudden spike in the requirement of their anti-hyperglycemic agents, and this probably could be because of insulin resistance that they face due to the stress of illness. Now, I always regard the dose of insulin as a very sensitive marker for somebody to project that is the patient improving or worsening. If you find that the insulin dose is increasing, we know that this patient is not doing well. But if you find that the insulin dose is coming down, if there's no other reason like a concomitant hepatorenal failure, you find that this is a good marker for telling us that this patient is doing better because his insulin resistance is improving. Also, when you plan a surgery, we know that the types of anesthesia has a direct relationship with insulin resistance. General anesthesia, the insulin requirement tends to go up versus local anesthesia. There could be difference in the energy requirements, and patients who are not eating adequately and are kind of in starvation, they can develop starvation ketosis. So, we need to ensure that there is adequate hydration of the patient at all times. And this is something that gets missed out often because everybody is concentrating on the illness. The nutrition and the hydration tends to get missed out, and that can be one of the reasons why patient tends to develop ketones and ketonuria. There is a possibility in the immediate post-op period, there could be a deterioration of the glucose tolerance. And there have been various studies, particularly in the post-cardiac surgical patients, where they have shown the blood glucose levels within the first 24 hours immediately after surgery decides the outcomes, the length of stay, and basically wound healing and many other sort of parameters. Some of the other considerations in hospitalized patients is we need to look at the choice of therapy that they are on. We know that glucocorticoid therapy can be an important determinant of hyperglycemia, and patients who get onto steroids may suddenly spike their blood sugars, and this is particularly true in patients who are on, they're getting assessed for transplants. So immediately in the pre-transplant period, we tend to give them a high dose of steroids, which can suddenly spike up their blood sugars, and they can even go beyond 400 and 500, and that becomes a challenge because the transplant teams are ready. They want to take up the patient, and the acute hypoglycemic response due to steroids can be a deterrent. In these sort of patients, we need to get them to better metabolic control so that it makes their post-transplant period safe, and probably there's less chances of graft rejections. It is important that a lot of emphasis is paid on diet, particularly the carbohydrate intake, which may be just balanced out between not giving them excessive and just the right amount. We need to ensure that there is a balanced diet that the patient gets in terms of macro and micronutrients, as well as there should be an accuracy of bedside monitoring of the blood glucose. At times, these can be affected by the hematocrit, the therapeutic levels of some of the drugs. Particularly, you may have drugs which can cause increased insulin resistance or counter insulin hormone levels. For example, patients who are in the critical care units, they may be on inotropes, they may be on steroids, and these may be some of the reasons why somebody may have a sudden increase in their blood sugar values. As well as high doses of ascorbic acid may interfere in some of the ways.